Well, good morning, everyone. Thank you for joining us today for the webinar, Wanting More Children While Facing an Inherited Risk of Blood Cancer. I'm Amanda Egan, the Patient Engagement and Clinical Program Manager for the RUNX1 Research Program. And in the window there is Katrine Erickson, who is our Executive Director. We are a nonprofit organization dedicated to supporting patients with RUNX1 familial platelet disorder with predisposition to blood cancers, also known as RUNX1 FPD. We do this through funding research, building and supporting our patient community, and facilitating collaboration across the healthcare ecosystem to discover treatment interventions that prevent blood cancer. So I'll be your host today and guide you through this webinar. We have two outstanding speakers that have graciously agreed to join us. Kayla Hamilton is a licensed genetic counselor at the Dana-Farber Cancer Institute, and she's dedicated to supporting patients with predispositions to cancers through many difficult decisions. And we just talked in her primary subspecialty as Huang. Kayla is also, thankfully, a member of RRP's Research Guided by Patients Committee. This is a diverse committee funded by PCORI, who you may know. This group is working with us to build an infrastructure for patients to serve as partners in RUNX1 FPD research that's really centered on patient-defined outcomes and preferences. And Katrine will introduce our other speaker.
Good morning, everyone. Thanks, Amanda. Thank you so much for joining us today. We really appreciate you taking the time. It's my great pleasure to introduce Dr. Andy Huang. When we learned that our community was really interested in vitro fertilization and pre-implantation genetic testing, I immediately thought of Dr. Huang. He's an obstetrics gynecologist who has specialized in reproductive endocrinology as well as in vitro fertilization. And he's a longtime friend and colleague of mine. In fact, he and I met at UCLA in a stem cell research lab working side by side together. And it's just a great pleasure to be able to connect with him again and find new meaningful collaborations through a webinar like this. So I know we'll all learn a lot from you, Dr. Huang, so thank you so much for joining us today.
Thanks for having us.
All right, so Ms. Hamilton will provide an overview of basic genetics, the RUNX1 gene, inheritance, and family planning options and considerations. Then Dr. Huang will introduce one family planning option, in vitro fertilization, and illustrate the basics of embryo development and pre-implantation genetic testing. So we are really encouraged today to have a significant number of clinicians with us. The content as presented is really intended primarily for a patient audience, but we hope this approach will really provide a great learning opportunity for everyone involved and hopefully serve as a nice model for how you clinicians can consider discussing this sort of information with your patients. At the very end, we will include a Q&A session, so everyone is welcome to ask questions of both speakers at that time, and we encourage you to go ahead and use that Q&A icon that should be at the bottom of your screen to ask questions as you listen along. I can watch for those and prepare to cue the appropriate speaker for the question. And you may use the submit anonymously feature, but just in order to maintain privacy, I won't reveal the questions for all attendees to see anyway. So please also do not use the chat function to ask questions because this can become confusing. I'll be looking at the Q&A icon for questions. So let's go ahead and get started. I will stop sharing my intro slide so that Kayla can share hers. Okay.
All right, just pull up my slides. Okay, can everyone see my slides? Perfect. All right, well, Amanda, thank you for the wonderful introduction and thank you for inviting me to speak today. As Amanda said, I'm a genetic counselor at Dana-Farber and I work very closely with families with a wide variety of leukemia predisposition syndromes. So this is a topic that I'm particularly interested in. And again, we'll be presenting it mostly directed at patients for educational purposes. But as I was putting this together, I actually found it really helpful for myself to kind of think more in depth about family planning and what information might be helpful for families to have. So I hope for all of the healthcare providers on the line that as you're listening to that part, it kind of gives you some ideas and thoughts as well. So as Amanda said, I'm going to be starting with an overview of basic genetics, talking about RUNX1 specifically. We'll talk about germline versus acquired mutations, autosomal dominant inheritance, and then focus more on those family planning options and considerations. So as everyone knows, the human body is made up of trillions and trillions of cells. So if you zoom in on any specific location in the body, like a drop of blood or a piece of skin, you'd find thousands of cells in that little piece. Inside of our cells, we have the nucleus, which contains the chromosomes. And if you unwind the chromosomes, you get our genetic information or our genes, which are made up of DNA. Each cell of the body contains 46 chromosomes typically, and we all inherit one copy of each chromosome from our mothers and one copy of each chromosome from our fathers. Tightly packed on all of these chromosomes are about 20,000 genes total, or 40,000 total since we have 2 of each. And the RUNX1 gene is on chromosome 21. You can see it down here. And that is where RUNX1 lives. When we think about chromosomes and genes, as I mentioned, chromosomes are really tightly packed pieces of genetic information. And the specific genes create proteins in our bodies. So proteins do things like create our heart and decide how our heart beats, creates our skeletal system, determines things like our hair color and our eye color, forms our brain and our neuronal system. So the proteins really do all of the different functions of our bodies. When we think about genetic mutations, it can be something really simple, like where most people have the letter C of DNA, someone could have a genetic change that turns the C into a G, and that is called a mutation. If you're a family member looking at your test report, you may see it referred to as a pathogenic or a likely pathogenic variant, and that just means that it's a known harmful genetic change. If you're looking at that test report, you might also see something called a C dot and a P dot number. So it might say C dot and then some numbers and a letter change. And that's just letting your healthcare team know exactly where in that gene your specific genetic change took place and what that specific genetic change looks like. So everyone has different mutations in genes, and it's helpful for the healthcare team to know exactly what the specific mutation in your family is. Mutations can create either an abnormal protein, so a protein that isn't formed correctly and can't interact with other proteins the way we would want it to, or it can create an absent or no protein. So mutations, again, look different within each family. And it's really important to know that we all have mutations throughout our bodies. Most of us just don't know what genes they are in. So if you do have a mutation in a leukemia predisposition gene like RUNX1 in your family, that doesn't make you abnormal. It's just you know about one of your mutations, and knowing about it can be really helpful for you and your family in terms of thinking about your healthcare. Jumping more into the RUNX1 gene itself, thinking about, well, what does it mean to have a mutation in that gene? Why do we care about it? So the RUNX1 gene is what's called a transcription factor. So it binds to other genes and helps turn them on and off. So you can kind of think of RUNX1 as a light switch in some ways. It turns on other genes and then it can turn them off, making sure that they're working properly in the different cells of our body. It also plays a large role in embryonic development, but most importantly, it plays a role in the development of hematopoietic stem cells. So hematopoietic stem cells are the early blood cells that have the potential to develop into all types of mature blood cells. So thinking about the white blood cells, the red blood cells, and platelets. We really need RUNX1 to be working effectively to have a healthy blood system. When people have mutations in the RUNX1 gene, they're said to have an autosomal dominant genetic condition called RUNX1 familial platelet disorder, or RUNX1 FPD. People with RUNX1 FPD have increased risks to develop low platelets or thrombocytopenia. They can have a normal number of platelets, and those platelets might not be functioning appropriately. People with low platelets or platelets that aren't functioning appropriately can have things like easy bruising or bleeding. So maybe they bleed when they brush their gums or have bruises all over their bodies, and they often don't know where they come from. And then we can also see an increased risk for cancers of the blood or hematologic malignancies. The lifetime risk for someone with a mutation in this gene is thought to be around 35 to 50%. And that's just coming from different literature, different studies that have been done looking at people with mutations in this gene and how often they tend to develop blood cancers. The most common cancers of the blood that we see are myelodysplastic syndrome, or MDS, and acute myeloid leukemia. But we can also sometimes see people developing acute lymphoblastic leukemia, lymphomas, or chronic myelomonocytic leukemia, among others. As you notice on the first bullet point, I bolded the word risks because this is not a guarantee. It's an increased chance or risk factor to develop cancer, but not everyone with mutations in this gene will develop it. And the average age at diagnosis is around 33 years old, not significantly younger than we would expect. If someone didn't have a mutation in this gene and developed leukemia, we might expect cancer in the 60s, but this significantly decreases the average age of leukemia onset. You might be thinking, well, how does having a mutation in that RUNX1 gene actually lead to cancer? What's going on there? So with this, we think about people being born with a germline mutation. If you look at this far left section of the screen, you'll see this would be a depiction of 2 copies of the RUNX1 gene or another leukemia predisposition gene. So someone that's born with that hereditary risk is born with a mutation on 1 copy of that. So they essentially have 1 non-working copy of that gene and 1 copy that's working appropriately. As time goes on, as their cells are dividing, they might acquire new mutations within the cells of the body. So those are not mutations that they were born with, they acquire them over their lifetime. And that's shown there. So if they develop a second mutation in the RUNX1 gene or in other leukemia and cancer predisposition genes, that's when they develop those increased risks and develop that leukemia or myelodysplastic syndrome. So being born with the 1 mutation is not enough to lead to cancer. We need to acquire new mutations as we age. This depiction here I pulled from Blood, and it's a great article that shows this diagram of how RUNX1 mutations lead to cancer. It's a more detailed depiction of the diagram that I just showed. So here you'll see these colorful cells that all have a black dot in them indicating a hereditary germline or RUNX1 mutation. As someone ages, going towards the right of the screen, you can see that they naturally develop new acquired mutations within those blood cells or in those stem cells. And then that ultimately, as certain numbers and types of mutations acquire, can lead to clonal expansion and development of MDS and AML. And you may have heard about things like reduced penetrance and variable expressivity. And that just means that not everyone with a mutation in this gene will acquire mutations. And you cannot assume that because some people in your family developed leukemia, that all other mutation carriers will as well. And that goes back to those pictures I just showed of the acquired mutations. Those are unique to each individual. So some people in the family might acquire more harmful mutations than others. In contrast to that, you cannot assume that because no one in your family has developed leukemia that no one ever will. Maybe in your family, mutation carriers have just had low platelets, thrombocytopenia, but it could still manifest as a cancer in individuals down the line. And mutations have to start somewhere. If other family members have not been tested for mutations in this gene, or if they were tested and tested negative, the mutation could be new in you or your child. And you may hear your doctors refer to that as de novo. It's just a fancy way to say the word new. If that's the case, you wouldn't expect to see a family history of platelet disorders or leukemia. So I think that's really helpful to keep in mind when thinking about what this gene and what this mutation might look like within your individual family. So in summary, risks are different for each family and each individual within a family. Sometimes for some genes and some genetic conditions, we might know specific information about individual mutations or genetic changes. So I do encourage you to talk to your doctors about the specific genetic change or mutation that's been found in you and your family members, and ask them if there's any data that they can share with you specific to that. If other families with this mutation seem to have a higher risk of leukemia than you might expect or a lower risk, make sure that you have all the information at hand. When we think about RUNX1 and many other leukemia predisposition syndromes, they can have autosomal dominant inheritance. There are also other inheritance patterns as well. So if your gene is not RUNX1, talk to your healthcare providers and make sure it's autosomal dominant. And if it isn't, make sure you understand the inheritance pattern that's unique to that gene and unique to your family. So with autosomal dominant inheritance, this diagram here is showing a male who again has 2 copies of that RUNX1 gene, and one of them has a mutation. And then his partner, the female partner, has 2 good working copies of that RUNX1 gene. So when they go on to have children, they don't pass on both copies of their RUNX1 gene, because then their child would have 4 copies of that gene, and we wouldn't want that either. So they either pass on 1 copy or the other. So the female only has 1 good working copy to pass on, and the male either passes on the good working copy or the copy with the mutation. And that's what leads to that 50% chance for each child to have the mutation. So mutations in this gene can be passed from men or women, and they can be passed to boys or girls in the family. But remember, while there's a 50% chance for your child to have the mutation, having a mutation does not equal developing cancer. They could certainly have a mutation and live a long, healthy life with no development of cancer. And again, as I mentioned, boys and girls are equally at risk to inherit the mutation. So after hearing that information and thinking about, well, what are the options for expanding your family? We talked a little bit about natural conception, which would lead to that 50% chance for a child to have a mutation and for a 50% chance for them not to have that mutation. You could also consider egg or sperm donation. So if the female partner has the mutation, you could get a donated egg. If the male partner has the mutation, you can consider getting donated sperm. You can also consider adoption. And then finally, in vitro fertilization with pre-implantation genetic testing. And the next speaker will be talking about that process in a lot more detail, and we'll be able to answer any questions that you have about that. One thing I'd say to keep in mind with these options, especially for natural conception, is that if you have received or are receiving treatment for leukemia, it's really important to discuss fertility with your doctors. Sometimes the treatment that patients might receive, particularly if they're getting a bone marrow transplant, can impair their fertility. So talk to your doctors about that, and consider sperm or egg banking if you'll be getting any treatment that could harm your fertility. When thinking about those options, they're obviously very personal decisions, and I think there are a few things that it's helpful for families to keep in mind when deciding what option is best for them and what option is right for their family. All of those options we talked about are not unique to RUNX1, they're not unique to leukemia predisposition or even cancer predisposition in general. Families with all different types of genetic conditions consider these options every single day. And each family has to decide for themselves how they feel about the genetic condition in their family. What is their perception of its severity, the expected outcomes for people who have that genetic condition, the treatment for it, and just the medical outcomes in general. And each person, we could have 20 people with the exact same genetic condition, and their perception of all of those things could be vastly different based on their own life, their own experiences, and their own beliefs. So there's no one size fits all option here. Your healthcare team can and should provide you with facts and information about the genetic condition in your family that can help you make this decision. I think it's being more informed can always do good and help you feel more comfortable and really understand all of your options. But ultimately, that decision is entirely up to you and your partner and your family. As I was making this, I thought about, well, what questions would I want to ask a healthcare team? If I was in this position, what do I think would be really relevant for families with leukemia predisposition syndromes? What do I wish my patients were asking me, and what should I be automatically sharing with them when they're thinking about these choices? So I think one key point is understanding if the mutation in your family is considered pathogenic or likely pathogenic. So as we discussed before, those words mean harmful or causing an increased risk of cancer. That means it's a true mutation. There can be other genetic changes that could be on your test report that are called uncertain or variants of uncertain significance. And that leads to a whole lot more questions and understanding what, if anything, that mutation is really doing in your family. So first, verifying that the healthcare team thinks that the genetic change that was found in you is definitely causing those increased risks of cancer in your family before making any family planning decisions based on that. And then thinking about, for the specific gene or mutation that might be in your family, what are the chances that your child will develop leukemia? Is it a 10% lifetime chance, or is it a 80%? And how do those different numbers sit to you? How do they feel to you? For people with mutations in that gene, what is the average age that people develop leukemia? So we talked a little bit about that average age being 33 for people with RUNX1 FPD. But the the range of that is quite diverse. We can see very young children developing it, and we can see people developing the leukemia in their 60s and 70s. And then again, we can see people having this mutation and never developing leukemia. So if you have a mutation in a different gene that's not RUNX1, definitely get that information from your team. Some of these genes cause much later risks than others. Also important to understand what type of leukemia could my child develop and what is the treatment like for that. There are many different types of leukemia, different prognosis, outcomes, and treatment available for them. So really having an idea in your head of if I were to have a child that developed leukemia, what might that look like? And again, what is the prognosis? What are their chances of survival? Another important concept is, do people with this particular genetic condition respond to treatment the same, better, or worse when compared to those with a random or a sporadic leukemia, a leukemia that developed not due to a hereditary risk? For certain types of genetic conditions, that condition can actually impact how someone responds. So for some genes, people can go into remission more easily, but have a higher risk for a new cancer down the road. So really understanding those types of concepts as well. And then if you were to have a child with this genetic condition, is there anything preventative that could be done? Is there any screening that your healthcare team might recommend with the goal of early detection or prevention of progression to cancer? So is there anything that you can do to be proactive about their healthcare to hopefully catch a cancer early? Also thinking about how often is the screening and what does it include? There might be a big difference for your perception of this if you're thinking about a blood draw once a year versus a bone marrow aspirate once a year, and how might that impact your lives. Also ask your healthcare team how effective they think screening is. Is the screening in the early beginning research stages, or do they have any data showing improved health outcomes for people who undergo this type of screening? And then finally, are there problems outside of the blood and outside of those cancer risks that people with this genetic condition face? So for certain types of genetic conditions, we can see individuals potentially being born with severe heart defects or other medical issues as well. So really understanding the full spectrum of health concerns that people with the genetic condition in your family might have. And then kind of spinning that around, and those are the questions that if it was me, I'd want to ask my healthcare team, and I'd want them to share with me to help be informed and make an educated decision. I'd also want to ask myself some questions. I'd want to think really carefully about what are my views on the cancer risks. Sometimes providers and everyone might throw around numbers about, oh, it's a high risk for leukemia or it's a low risk for leukemia. But what do those numbers really mean? So asking for the data and then sitting with those numbers and thinking about, what does a high risk sound to me and what's a low risk? We all have different perceptions of those things, and that's completely okay. So really thinking about your personality and your life and what those things feel like to you. And then also really thinking about how have your family's previous experiences with this genetic condition shaped your views. Thinking about people in your family who have had leukemia and what it's been like for them. Thinking about other people in the family who have made family planning decisions, and really thinking all of that through and considering how it might be influencing and shaping your decision. Think about what your support system is like as well. Who in the family would you want to or feel comfortable sharing this information with, thinking about your options and getting their input as well? Or is it something that you would like to make independently or with your partner? And then also, would it be helpful for you to talk to other families about their experiences? Maybe if you're leaning towards adoption, talking to other families who have adopted a child. If you're leaning towards natural conception, talking to other families with this genetic condition who have had children naturally. Thinking about IVF, talking to families about that. So really trying to get a broad view. Obviously, someone else's experience will not be exactly like your own, but just to try to become well-informed and have a broader understanding. And then finally, considering your own beliefs, experiences, and religious views. All of these things shape our decisions every day in many aspects of our lives, and I think they play a particularly important role when considering family planning. And that's not a bad thing at all. It's kind of part of who we are, and it should play a role in that. So really thinking all of that through and thinking about what is most important to you and how all of these things might be shaping your decisions. And then also thinking about what's most important to you and your partner, how strongly you feel about having a biological child, how strongly you feel about these different family planning decisions, and always making sure that the partner who doesn't have the mutation feels comfortable opening up and sharing their experiences, watching those that they love have this genetic condition. I think their experiences are just as valid and just as relevant when considering family planning options. And if you have other kids with the genetic condition in the family, make sure they know that just because you are considering your options doesn't mean you love or value them any less. They may be scared or wondering, why are mom and dad thinking about not having another child naturally? And I think it's a really important that families are able to be open about these conversations and make sure that their families and their kids know that they're loved and valued, and that this doesn't change their parents' opinion or view of them in any way. And then finally, having a mutation in the family is not your fault at all. We all have different mutations. Again, most of us just don't know what genes they're in, but I know a lot of families can really struggle with feelings of guilt when thinking about passing on a genetic risk for cancer. And I try to make parents spin that around a little bit and think about, their parents who maybe passed this on to them. How would they feel if their parents were feeling guilty and blaming themselves? They wouldn't want them to do that. So making them put themselves in that shoe and spin it around can be really helpful to help reduce some of that guilt. And ultimately, this choice is up to you. It's completely yours, and there is no right or wrong option. Again, you could have so many families in the same situation, and everyone might make a different choice just based on what's right for them at that point in their life and what's right for their family. Again, your healthcare team can help provide you with information to make an informed decision, but they cannot and should not make any reproductive decisions for you. They should just be supporting you and helping you decide what is best for your families. And with that, I will hand it over to Andy to talk a little bit more about that in vitro fertilization option.
Thank you so much. Can everybody see my screen?
Not yet.
Okay. All right. Can everybody still see me?
Yes.
Okay. Tested it. Okay, here we are. I apologize. Amanda, do you have my slides by any chance for some reason?
I do, and I can share them, and you can just let me know.
Yeah, that'd be awesome.
No problem. Let's see. Let's make sure I can do it.
I tried sharing it on mine.
Sometimes okay. Can you see your first slide, everyone?
Okay, great.
Yeah, how about okay, as long as that looks good, we will,
perfect. So
you just let me know.
Yeah, okay, thank you. So Kayla, thank you so much. That was amazing. I spent years with Katrine in a stem cell lab hearing about all of her dedication to RUNX1, and this was a great kind of presentation that allows me to kind of really understand RUNX1 and how it applies clinically. So super duper helpful. Thank you for that. I think three important messages that I got from your presentation, Kayla, was first and foremost that as we talk about planning families, is that there are options. So it's not just one option, and it doesn't have to be directed towards the fertility option of IVF with genetic testing. That adoption, that using egg donor or sperm donor are many options. So I think that's important. And today I'll talk about, the one option that's related to kind of my specialty, which is fertility, but by no means is that the only option. A second important thing that Kayla brought up was that this is truly a multidisciplinary field, that we have scientists, and this is where kind of the RUNX1 research program has brought us together. We have scientists, we have geneticists, we have oncologists, we have fertility specialists. So it really is a multidisciplinary field, and I think it's important for us to recognize and continue to work together in that front. And the last thing that I wanted to just emphasize was that, and ultimately, any decision on how to grow a family is a very personal and family decision. So while the multidisciplinary team is there to help everybody kind of with those decisions, really our goal and our job is to provide options and help the families kind of decide on what's best for them. So again, my specialty is on the fertility side. I am blessed to be in a practice here in Southern California. I'm at Reproductive Partners, and we have multiple offices here. Next slide. So IVF is something that we've been doing as fertility specialists since 1978. So we've been using it for decades. To date, there are millions and millions of children born from IVF, and it actually accounts for about 1 to 2% of the world's population these days. Now, IVF may seem very daunting, but here's just a simple kind of schematic that shows kind of the process of IVF from the beginning, where women get ovarian stimulation to help mature follicles so that we can retrieve oocytes. This process of maturing follicles to get the eggs takes about 5 weeks from beginning to end. And then once we get the eggs, then we can fertilize it with sperm. And then we watch the embryo start to develop. And it's at this stage that we can see embryo formation become. Nature a lot of times will weed out some of the bad ones. So we'll watch eggs fertilize. We'll watch these fertilized zygotes then grow on over the course of 5 to 6 days to become embryos. Once they get to a more advanced embryo stage, this is where we can more safely test these embryos for very specific either chromosomal or genetic disorders. Kayla reviewed kind of a very good background about the genetics of autosomal dominant disorders. So we'll talk a little bit about that and how we can work to screen those disorders and try to promote healthy pregnancies and healthy families. Once the PGT testing is done, these embryos are then frozen because it takes a little bit of time to get the results back. When the results get back, we're now able to screen embryos that may carry specific genes and the ones that are non-carriers. Then we can specifically take the non-carriers and carefully transfer one of these embryos back into a woman's uterus to achieve a pregnancy. Next slide. So this is a diagram showing kind of what we can do in our laboratory. And so over the last decades, we've been able to advance kind of what we can do in our laboratory such that we can get the egg, which is the day 0, so that's an oocyte. We put it with sperm, and we watch it fertilize to become a zygote. Over the next 3 days, we watch the embryo start to divide and grow. So it becomes 2 cells, and then 4 cells, and then it cleaves again to become 8. In the old days, we used to do testing of embryos on an 8-cell embryo after day 3. And this was prior to advancements in freezing techniques. So in the old days, we would have to test on day 3 when an embryo only had 8 cells. But you can imagine when you use a needle and you puncture the embryo, when you suck out one of those 8 cells, it can actually cause injury. So we saw that pregnancy rates weren't that good on day 3 biopsies. So as tools in our lab got better, we have taken now day 3 embryos, which have 8 cells, and then they start to more rapidly cleave to become 16, 32, 64. By the time we get to about day 5, day 6, an embryo now has about 100 cells. So it's a more robust embryo. There are 2 cell layers, and we can go to the next slide. And so here is kind of a zoomed in picture of a more advanced embryo. And so this is what we call a blastocyst. It takes about 5 to 6 days to get to this stage. When you get to this stage, the breakdown of the embryo is the zona, which is the outer shell. There's also the trophectoderm, which is the cells on the outside. These are going to these will subsequently become the placental cells. And then the ICM diagrammed here is the inner cell mass, which is going to be the embryo and the fetal cells. So today we can actually thin the zona and then go in and aspirate a few cells from the trophectoderm. And from these cells, we can then send off to do the genetic testing that we want to do. Next slide. And so what are the genetic tests that we can do? Well, there are 3 different types. And we're going to focus on the top, which is the PGT-M, which is looking at very specific monogenetic disorders. In addition to that, though, we can also look at aneuploidy, which Kayla's slide of showing chromosomes is specifically what we're looking at and making sure that there are appropriate pairs of chromosomes. We can also do PGT to look at structural rearrangements like translocations, which are a very common cause for recurrent miscarriages. But one of the great tools that we've been able to utilize is specific to PGTM. And PGTM is looking for very, very specific genetic disorders, whether it's autosomal dominant, X-linked, or autosomal recessive. Next slide. So the PGTM process takes some time. The first important thing is a case review. So when a couple has found out that they are a carrier of RUNX1 or a myriad of other disorders, whether it's Huntington's, SMA, but anytime a couple comes in with a gene specific that has clinical outcomes that they're concerned about, the case is reviewed with geneticists to make sure that indeed a probe can be created. And more than 99% of the times, a probe can be created for that gene, okay? So that case is reviewed. This usually is an initial consultation with the genetics lab that takes 1 or 2 weeks for them to be able to review the gene of interest. And then they begin the preparation of creating the probe. This is a very in-depth process that takes about 8 to 12 weeks. So when a probe has to be created, it's very specific to the mutations of the couple. So for cystic fibrosis or RUNX1, they're able to sequence and find out exactly kind of where the mutation is, and they create a probe specific to that. Then we do the IVF process. That process takes, as I said, about 5 weeks. Once we get the eggs and create the embryos biopsied, and then it takes about 2 weeks to get the results back. And then once the results are back, we're able to screen which are the healthy embryos, which are the unhealthy embryos, and then we'll transfer one healthy embryo back into the woman. Next slide. So we've seen the diagram in terms of inheritance. Here on the right side, we're just looking at this is an autosomal recessive model. So in yellow, you can see the gene of interest. But for RUNX1 and autosomal dominant disorders, even one gene can have a 50% affected family rate. So know that here, I'm just showing the diagram in terms of, you know, finding a probe specific to genes. When you talk to the genetics labs, they will tell you that they have a very good success rate in creating probes for specific genes. And it's, again, over 99% of the times they're able to create that specific probe. And it allows us to detect over 95% which embryos will be affected. And so we can very accurately screen for these disorders. Next slide. And the ultimate goal then is to find the healthy embryos that are created from the genetics, the eggs and the sperm, and do everything we can so that we can, you know, screen and eliminate the potential gene of interest so that we can achieve healthy families. And I wanted to keep my part short so that we could also have plenty of time for questions.
Thank you, Andy. Okay, I think I've unmuted. Yeah, thank you. I appreciate that. Yeah, I appreciate the basics, and I think we have a good, let me pull up my Q&A session again. I'm just adjusting. Thank you, both of you. I think that was really clear and a really good starting point, or more than a starting point for everyone. There were tons of questions. What I didn't mention at the beginning is that this was a topic that patients brought up a lot as I've talked with patients over time, and I think you hit a lot of their other questions as well in your broader discussion, Kayla. So thank you. I have 2 questions already, and I will read those out. And if others have questions, feel free to type them into your Q&A window, which should be at the bottom. So first question comes from a patient. It says, so this is more for Kayla. Can you explain some of the variants? Oh, sorry. Let me move that question. Some question moved over for some reason. So let's see. So can you explain some of the variants of MDS AML based on the acquired mutations? In this family, each of them had a different final mutation that led to a different type of AML. This is a big question, and I will mention, Kayla, you could take a shot at it. And the other thing I'll mention is that we actually have a seminar this afternoon, a webinar that will dive into some of this in more detail. So Kayla, if you'd like to address
Sure.
this.
I can address it a little bit. So it's part of what I was mentioning with the ideas of reduced penetrance and variable expressivity. So reduced penetrance means that not everyone with the same germline mutation will develop cancer. And variable expressivity means that the people with that mutation who develop cancer might develop different types of cancer. So maybe one person in the family develops AML, and one person in the family develops ALL, and maybe someone else just has some mild thrombocytopenia. And a lot of that diversity in terms of that clinical picture does come from the specific somatic acquired mutations that someone might develop over their lifetime. So for all of us, everyone who has a mutation in this gene and everyone who doesn't, we're all acquiring new mutations in our blood as we get older. And people with RUNX1 might be more likely to develop a second mutation in that RUNX1 gene, or mutations in other leukemia or cancer risk. They're called tumor suppressor or oncogenes that can lead to that diverse spectrum of clinical outcomes. But it is definitely a little bit hard to predict. And that's where a lot of research is going, looking at when we're looking at bone marrow aspirates or looking at those new acquired mutations, how to predict which ones are going to transform into a specific type of leukemia and when that might happen. So when does that burden of acquired mutations become strong enough that a leukemia is about to develop? And that's a really active area of research. Part of the idea of kind of cancer screening is if we can do this and we can say, oh, they're about to develop leukemia, we're going to catch it before it happens. But for the most part, I would say it's really hard to predict at this time, but I don't know if any of the other panelists have any thoughts on that too.
Well, I just want to add, Kayla, that was an excellent explanation, and you're absolutely right regarding research. This is a hugely important question that we have a number of groups really interested in, and we've got Dr. Anna Brown presenting at a webinar later this evening or afternoon, depending on where you are, who will be looking at next generation sequencing data sets to start understanding what are some of those common co-occurring mutations. And she actually presented in October a data set of patients who had malignancy and looked at the common co-occurring mutations there. And as Kayla had mentioned in her presentation, one of the most common co-occurring mutations is actually a mutation in the second RUNX1 allele. But there are others that are coming up as well, like BCOR and PHF6, and we just don't understand what the sequence is. Are they the first to come out? Are they the last that really pushes a patient from, pre-leukemia to full-blown leukemia? These are just all really important questions, and the natural history study that's ongoing with the NIH is that's a really important question that they're addressing by looking at patients longitudinally or over time and seeing how the blood changes and what kind of mutations are arising. So, but thank you, Kayla, for that answer. I think it well said.
Thanks. Okay, so another question. This looks like for Andy. So for some reason, these are sorry, just a second. These are moving from.
Oh, I'm trying to answer them as we go.
Oh, I see. You know what?
But it's good to bring them up.
Let's not, sorry, really quickly, when you hit answer live, or you're answering them, they actually move into answered and then everyone can see them. And so I'm hitting dismiss so people can't see them. I'm sorry. So I'm just trying to hide, for confidentiality reasons, let's just talk through them live. Sorry, thank you, Andy. We didn't clarify that clear enough. Let's see. So let me go over to a couple people have been asking about cost. Right. So basically, can you please discuss the anticipated costs for IVF, PGM, and PGM for families? And now I'm seeing you actually answered them. Okay, sorry, technology troubles. This one I can reopen so people can see because it was asked anonymously. And so they asked costs, and you're saying you want to just go ahead.
Yeah. So, and there are different, so costs depend on sometimes by states, because some states have mandated coverage. So California is a little bit behind, but there are some more progressive states like New York, New Jersey, Massachusetts, where fertility is covered. How much of it is covered, I'm not sure. I know that when there isn't coverage, that the cost of IVF will probably range about 15 to 20K. The additional testing of the embryos, because not everybody does testing of embryos. So the IVF process kind of alone is probably about 15 to 20,000. And that's because of surgical fees, monitoring fees, medication fees that all add up. These are very expensive, highly purified hormones that we're utilizing to allow multiple follicular development. So about 15 to 20,000 kind of would be kind of the standard out-of-pocket fees. And then about 5 to 8,000 from the genetic side of things to create the probe, to then analyze the embryos. So it is not cheap. Unfortunately, the cost of fertility treatment is a hurdle for many. But there are foundations that are available, and they are uniquely dedicated to the reason why we're meeting today, and that is for cancer risks. So I know that Live Strong is a foundation that we take care of a lot of women who get the unfortunate diagnosis of breast cancer, and so they're not ready to start their families yet, and they may or may not be ready to create embryos. But there are foundations that are very specifically dedicated to helping with alleviating the cost and burdens of fertility care. And so that's something that I'll work with the team here to kind of come up with a list and have you distribute it to anybody who's interested.
Perfect. Thank you. And that, yeah, we someone else had a question, and it looks like you answered it. That, yeah, we're glad to share resources. We'll just watch for a follow-up email. All of the attendees, we'll send those to. Okay. Another question was very good info. May I ask how many embryos are tested at once? And Andy, you said as many as are created. Especially because for autosomal dominant transmission, that's going to be a 50% affected rate. So, and this is where age also plays a role too, because the younger you are, the more eggs you have. The more eggs you have, the higher, that 50% kind of inheritance rate. So, age and ovarian reserve are other variables that fertility specialists will really look at in counseling you, kind of whether it makes sense. Because when you look at a typical 20-year-old who might easily make 20 eggs, and those 20 eggs will then have, 2/3 will fertilize. So now we're down to 12 or 13 zygotes. We'll watch those grow and mature, and we end up with 5 or 6 embryos. So it's really important to understand the numbers, because there's going to be a natural attrition of eggs to embryos. And when you get to the stage of embryos, if we start with 20 eggs, we might end up with anywhere from 6 to 10 embryos. Of those 6 to 10 embryos, in addition to looking at the gene of interest, we'll also be able to look at chromosomal normality. And for any age woman, there's going to be a relatively substantial subset of embryos that are aneuploid. So that have an extra chromosome 21 that makes it Downs, or extra 13 for Patau syndrome. So while we're looking for a very specific gene of interest, we're also going to screen and make sure that the chromosomes are appropriate. So a 20-year-old could make 20 eggs, end up with 10 embryos. Those 10 embryos will give us 6 euploid embryos, and then only 3 of them might be, right, the 50% of the 6 would be 3 embryos that would be screened for. That's a healthy 20-year-old. So when these discussions are made with geneticists and your healthcare providers early, this is a critical time that we're able to take advantage of the fact that younger women will have healthier eggs that will translate to more embryos to screen for. In contrast, when a 40-year-old comes into the office with a little bit of infertility and a family history of genetic predisposition for cancers, we're now working with 10 eggs. 10 eggs will translate to 3 or 4 embryos. And now the euploidy rate on 4 embryos for a 40-year-old may be 1 in 3 or 1 in 4. So we've gone from 4 embryos to 1 euploid, and then that's a 50% chance of having that autosomal dominant gene. So the better we do at counseling and getting the information out there, that there are fertility options. And again, really critical, what Kayla said, is that these are options. If a 40-year-old comes in and her ovarian reserve is low,
the probability of me finding a healthy embryo that is transferable is going to be low, it's really important, because with the cost of fertility, to go through all of this is not easy for many families. So the better we do in terms of counseling and getting patients at an appropriate age to their healthcare providers, whether it's fertility specialists or not, the better odds we have of finding those healthy embryos. So youth plays a critical role in allowing us to find the embryos that are healthy. To answer the question in a long way, the more embryos we have, the higher the probability we'll find that the chromosomally normal and genetically normal embryo.
Great, thank you. And you might see that someone was wondering if these numbers that you're citing are the same for Black, white, Latina, Asian, etc. women.
Age is the best predictor in terms of health of eggs. There might be differences in ethnic kind of, but the differences are very small. So the highest predictor in terms of finding healthy embryos is going to be age.
Yeah, okay. And then I think that question was around this discussion, but in terms of RUNX1 FPD, we have not, I'll mention that we haven't seen any leaning towards a certain ethnicity or race, right, Katrine? Yeah.
That's correct.
Yeah, I don't know if Kayla, you have any thoughts on that in your...
I agree. It seems to be pretty diverse. There are some types of genetic conditions, and if there are families listening that have other genetic predisposition syndromes on this call, there are some genetic conditions that are more prevalent in certain groups of people, like maybe there's a group from Finland that has a genetic change. But for RUNX1, it seems to be pretty equally distributed.
Yeah. Okay, great. Let's see. We have one more question, I think. Andy, what are some of the characteristics of a mutation that can contribute to, I guess either of you could answer this, that can contribute to challenges in cases where a probe is not available for IVF?
So that's a great question. So to get an update, I reached out to a geneticist from the laboratory that does the PGT testing. The vast majority of the times, they're able to create a probe. The difficulties are the more generations and the more iterations of the mutations that they're able to assess, the better the probe will be to screen for the gene of interest. So oftentimes in the preparation phase, in addition to sequencing the gene from the family, they like to get other generations of the parents. So the problem with certain probes is that if they're not able to get, multiple, assessments from other family members. So oftentimes when there are other members that they're able to screen for, they get the sensitivity of the probe will be better. Now, it also depends gene to gene. There are some genes that are easier to kind of create a probe for. By the way, RUNX1 is a gene that has been screened for. So I did confirm there have been cases of RUNX1 that have already been kind of probes been created for families. So we know that is a gene that can be screened.
Okay, great, thank you. I think I saw one more question. That might actually be it. One person did ask a while back whether we're recording the session so that it can be shared more broadly, and we are. We so appreciate Kayla and Andy that you're willing for us to record this. I think there's so much learning that we could that could be gathered from this. So I'm already thinking about like mini clips I can share for different topics, like within your discussion, Kayla, because I think you hit on a lot of topics that various patients have had, questions that patients have had. I think that's all of the questions that came through. Any other last thoughts that you all have, or?
Amanda, one more thing is that, infertility is a very personal kind of issue. So anybody who's participating today, if they ever kind of want to reach out kind of privately, you can give them my contact info. You can give them my cell phone. I'm happy to reach out to anybody, to discuss the more personal kind of infertility side of things. But there are options out there for everybody. And so, that I think that was really important, because by the time patients come to me, we're focused on just that one option of creating embryos to screen for, but there are other options. And I think that was, really important for Kayla to kind of hit on, because, You know, when we get to the point of, you know, the discussion of family planning and things like that, you know, we often think that there's only one option, but there are other options. And I think the points that Kayla mentioned are all very relevant and very important for us to talk about.
Yeah. Thank you, Andy. That's really generous of you to share your contact information. We will blast that out. Just kidding. We'll be following up with, like I said, some resources and some information, and we'll include that. Maybe not your cell phone number, but your information. So actually, at least one other question came in. If a probe has been created already, can it be reused if it's for a family with the same mutation? That was a really good question.
Yeah, really good question. The laboratory still likes specific probes in case there are any variants in the mutation. Yeah, so if it's the same couple, obviously, for a sibling cycle, the probe's already created for that family. That's easy to use. But I know that kind of when we're working with, you know, extended family, probes need to be recreated.
And we talked about this yesterday when we prepared for this, right? There are, I forget how many specific mutations in the RUNX1 gene that we're at right now, Katrine? Do you know where we are?
104.
104. So there would need to be a unique probe for each of those, right?
Correct.
Every single mutation you have, a probe needs to be created for it. And then you're saying for a single mutation, that probe could potentially not even be reused or recreated, I guess.
Right, because there are some genetic mutations that have very, very similar kind of cystic fibrosis, a very specific kind of mutation points. But even then, the genetics lab doesn't like to assume anything. They want to create very specialized probe for each unique mutation.
Okay.
Well, gotcha. You have to remember that even in a given gene, there are other variants that are unique to an individual or to a family that are not pathogenic, but they're still a variant, so it changes how the probe is designed.
Got it.
Yeah.
Wow. Fascinating, complicated, and all of that. Great. And someone just commented, thanks so much, everyone. This has been really helpful, especially for my partner who has just learned what a chromosome looks like. We live in Australia, so really appreciate the Zoom sessions. Yeah, so this has been really great. You know, there's so much that is unfortunate about this time, but so much that's been fortunate. It's really allowed us to bring up these opportunities for learning that you know, we're trying to offer them at times where people can join across the world, and people are. And again, we'll record this and share it. I think this will be really useful. This is useful for me. I'm sure it's useful for many. So thanks, everyone. We are good. I think we really appreciate it. Thanks again, Kayla and Andy.
Yeah, thank you. Thank you for the invitation to speak.
Yeah. Thank you,
thanks.
everybody.
All right. Have a great Thursday or Friday for some. Okay.
Bye-bye. Have a good
Bye,
one.
guys.